Today we're going to actually kind of get into one of the drug classes more in detail. I was asked to talk about penicillins and cephalosporins today, and let's go ahead and get started. Oh, and again, my name is Julie Harting, and I'm one of the infectious disease trained pharmacists here at University Hospital. So just a quick review of beta-lactam antibiotics. They do work by cell wall synthesis. They bind to the penicillin binding proteins in the cell wall, and by binding the penicillin binding proteins, they disrupt peptidoglycan's ability to create a stable cell wall. Looking at the picture on your right, if you look at the red ring or the red square, that is the actual part of the beta-lactam antibiotic that binds to the penicillin binding protein. That is the beta-lactam ring. Some of the other things that are colored in this molecular structure, on just to the right of the red and blue, that's a thiazolidinone ring. And the big R on the left that's in green, those are multiple different ways that we can manipulate these different antibiotics by giving them more gram-positive coverage, gram-negative coverage, solubility, and those are what we call our different R groups. The beta-lactams are bactericidal, so they will cause cell lysis and they will cause death to the bacteria. They are time-dependent, and they're a pregnancy category B. And the next slide is just a picture of that mechanism of action where the beta-lactam is going to be interfering again is with the penicillin binding protein, and the penicillin binding proteins are responsible for the cross-linking of the peptidoglycan. So if you kind of think of, a building with scaffolding, basically what the penicillin binding proteins do is they help that scaffolding stay as an intact structure. And so if you don't have that structure in the cell wall, then the cell wall lyses and the bacteria lyse and die under osmotic pressure. There are some important requirements for beta-lactams to work, and so they need to be working on an actively growing bacteria that is actively making a cell wall. They need to be in the presence, or actually without the presence of some inactivating enzymes, which we'll talk about. We'll talk about some important beta-lactamases. And they also must be able to enter porin channels, especially within gram-negative bacteria, and reach their target, which is where the penicillin binding proteins are in the peptidoglycan layer. So I have a picture on the right. You can see an antibiotic. Let me put my cursor here. We've got the antibiotic approaching the bacteria and trying to enter especially the gram-negative bacteria through this porin channel to get down to the peptidoglycan layer where the penicillin binding proteins do their work. Within beta-lactams, we do have 4 important drug classes. There are the penicillins, the cephalosporins, carbapenems, and monobactams, and today we're just going to be reviewing the penicillins and cephalosporins. So with natural penicillin, it was discovered in 1928 by Alexander Fleming. It actually is a pretty interesting story how he discovered it. If you can look to the agar plate on the right, Alexander Fleming noticed on one of his agar plates that was growing some mold that there was actually this zone of inhibition, and we'll kind of draw a big circle around here around the mold. And he kind of wondered, well, what is it that seems to be preventing this bacteria that is streaked across the state? What is the mold possibly producing that is preventing this bacteria from growing in this area of inhibition around the mold? He discovered that was Penicillium notatum, and so hence the name penicillin. What's actually streaked across the plate here is Staph aureus, which is very interesting that this penicillium type product that was being produced killed Staph aureus back in 1928, and as we go through the lecture, we're going to learn that penicillin really isn't effective against Staph aureus on its own anymore. The first dose of penicillin was given in 1942, and that was for a patient with streptococcal septicemia. We have several different products of penicillin, and we have penicillin G and penicillin V. In the penicillin G products, they're available through the IV and IM routes. IV is penicillin potassium or sodium. IM is available as either a short-acting or long-acting product, and we're going to really talk about this. We're going to go through a case with syphilis. and talk about how these IM products can be very confusing and can often lead to medication errors. Of note, the penicillin G is dosed in million units instead of milligrams. The oral formulation of penicillin is called penicillin V. I always teach my students that the only way I really remember that is thinking that V equals vegetable, and I eat vegetables, they go in the mouth, and so that's how I remember that V is for the oral and G is for the IV, so if that helps you. It's also called penicillin VK, and it was specifically developed to be more stable to gastric acid and able to be absorbed better than the penicillin G product. Getting into a quick case. So this is a case of a 28-year-old man. He's an asymptomatic HIV infection, very adherent to his antiretroviral regimen, which is a tripla. He has had 2 new sexual partners within the past 6 months, and he did admit to not using condoms frequently. He's really here at your clinic today, not because he's concerned about anything related to an STD, but really just for follow-up evaluation and reviewing his most recent labs. On physical exam, really nothing kind of popped up except for some shoddy axillary and inguinal lymphadenopathy, which was unchanged from previous exams. His neurologic exam was normal. And looking at his labs, his complete metabolic panel is normal. His CD4 cell count is above our goal of 500. And his HIV viral load is undetectable, which is also a goal of being on antiretroviral therapy. What's interesting, though, is that there is a serum rapid plasma reagent titer of 1 to 16, which was compared 6 months ago, and that was negative 6 months ago. And results of a treponema antibody absorption testing are positive. So the treponemal antibody is related to which organism? That's right, Treponema pallidum, which is syphilis. And really what we want, I'll get into our goals of therapy in a minute. So the question is, which of the following is most appropriate for treatment? So aqueous crystalline Pen-G, intramuscular benzathine Pen-G weekly for 3 doses, oral doxycycline for 14 days, or a single intramuscular benzathine penicillin G. Just for a quick review of different formulations for syphilis, because it can get very confusing, looking at these different formulations that are available within the penicillin within penicillins. The treatment for primary, secondary, and early latent syphilis is the IM benzathine penicillin 2.4 million units times 1 dose, and that is the long-acting penicillin product. For tertiary and latent syphilis, it's IM benzathine penicillin, but for 3 doses. So that kind of knocks out our answer number B on the previous slide. For neurosyphilis, it's a completely different product. It's IV Pen-G, 18 to 24 million units a day. And an alternative would be procaine penicillin, which is a short-acting intramuscular penicillin with probenecid. And just as a reminder in our patients that do have syphilis and are treated with a penicillin, there's a unique adverse event that can occur called a Jarisch-Hersheimer reaction, which is an acute febrile reaction that occurs after 1 dose of a penicillin product and typically manifests as fever, headache, and myalgia. So, looking at our different products, and this is where a common medication error can occur, within the intramuscular penicillin products, on the left you've got Bicillin LA, which is the benzathine penicillin. It only contains benzathine penicillin, and so therefore it is the appropriate drug, just going back to the previous slide, it is the appropriate drug for primary, secondary, early latent, tertiary, and late latent syphilis. The products that are not, the product on the right, which is a combination of the benzathine and procaine penicillin, is actually not indicated for any stage of syphilis. It's a mix of a long-acting and a short-acting penicillin, and so if we just look at these appropriate treatment options for any of the stages of syphilis, having a combination product is never appropriate, and it's never indicated. So just make sure when you're thinking syphilis and you're thinking of the intramuscular, you're writing for LA and not CR. What we're going to do is kind of go through the antimicrobial spectrum of some of these different penicillin products, and we're going to kind of take penicillin and build on it as we go all the way through to Zosyn. So starting with penicillin, it is primarily considered a gram-positive agent, and really for today primarily covers streptococcus. You know, as we know from that story with Alexander Fleming, penicillin, or at least the kind of the product that was produced by the Penicillium mold, that product used to have activity against Staph aureus, and now with penicillinases that are being produced, which is a type of beta-lactamase, we don't really use plain penicillin for Staph aureus anymore. I actually have seen a Staph aureus. It was an MSSA that was penicillin susceptible, but it was in a gentleman that had a Brody abscess in his tibia from when, let's see, I think he was probably in his 60s when we saw him in clinic, and he had been hit by a baseball bat in his tibia 4 decades prior and had a staph infection in his tibia. So it's kind of interesting to see this sort of dinosaur of a Staph aureus that had been so well protected in the tibia for decades that still had susceptibility. But you'll rarely see that today. Wanted to also let you know that Enterococcus also has, or you can also use penicillin for Enterococcus. You know, it's not 100% susceptible anymore, and so you'd always want to call down to your microbiology lab and double check. And we'll talk about when we get to ampicillin, which is the drug of choice for Enterococcus, why we might want to go back to penicillin sometimes. So I'll talk about that when we get into ampicillin. It has very little coverage against gram-negative organisms, although one clinical pearl is for Neisseria meningitidis, which is a gram-negative diplococci. And penicillin alone does actually have some anaerobic coverage, although it certainly doesn't cover some of our kind of very clinically important anaerobes like Bacteroides fragilis. It is considered drug of choice for actinomyces, which is a gram-positive rod that's normal flora in the mouth and can cause abscesses throughout the body. And it is our drug of choice for Treponema pallidum, which is a spirochete and can cause syphilis. Really specifically for strep pneumo, I wanted to kind of talk about the antibiogram locally here and just remind you that for strep pneumo, there are different cutoffs for what is considered susceptible, intermediate, and resistant based on the site of infection. And this is a really unique thing that we have susceptibilities based on a site of infection for a bug-drug combination. And I think it's something that you'll see happening a little bit more in the future, but right now this is the one big important distinction. So if you look in the bottom of this antibiogram in red, you'll see that for strep pneumo, there are different determinations of what is susceptible, intermediate, and resistant based on whether or not you're treating an infection anywhere in the body versus in the brain. And so what you'll see in the blue box is for our non-meningeal breakpoint, we have very, very good susceptibility of penicillin to strep pneumo, meaning that oftentimes, really 95% of the time, you could use penicillin for treatment of a strep pneumo pneumonia, for example, and you don't always have to stick with ceftriaxone. You can de-escalate down to penicillin. However, look at the difference when we're looking at those requirements for penicillin when you need to treat strep pneumo in the brain. So it drops all the way down to 68, only 68% are susceptible, and that's because penicillin really doesn't have great drug concentrations into the CSF. And so we need to have a very, very highly susceptible strep pneumo in order to consider it, in order to consider those little drug concentrations enough to be effective. Just to make a comparison to ceftriaxone, which is in the green box, ceftriaxone is 100% susceptible. I believe this is the 2013 antibiogram. Ceftriaxone is 100% susceptible, and the meningeal breakpoints are 93%. And these antibiograms are available to you on NetAccess. So kind of sad for penicillin, right? That was a pretty wimpy list of bugs that penicillin covers. You know, some strep, some enterococcus, and a few little niches like syphilis. So, you know, really what we're looking at is this very sad story of penicillin being developed in the 1940s, and very quickly within the next decades, you kind of lose susceptibility to for staph, and really penicillin just isn't that great for broad use anymore. Just as a reminder, though, that if a strep is penicillin susceptible, that is still the drug of choice, and that penicillin product will kill better than any other drug. So, you know, we were looking at that timeline and we saw that there's a lot of resistance, and really the problems with resistance have to do with this binding to the penicillin binding protein, where the bacteria can actually change their penicillin binding proteins and alter them so that the antibiotic doesn't bind to them anymore. And, you know, kind of when you say penicillin binding proteins, it's almost like saying, oh, I want a Coke when you really want a Sprite. So there are lots of different penicillin binding proteins, and they all bind to different beta-lactam antibiotics. So it's not like there's just this one penicillin binding protein that's there, and if it doesn't bind, then you're out. There's a huge family of them. And so the bacteria can either have overproduction of penicillin binding proteins, or they can make their penicillin binding proteins have less affinity for the antibiotic. We also have beta-lactam inactivating enzymes, so beta-lactamases. There can be changes to porin channels where the bacteria can actually change those. A lot of the porin channels are ion regulated, and they can either stop making porin channels so that there aren't as many in the cell wall, or they can change the actual nature of the porin channel so that it doesn't allow different charged particles to enter where they used to be able to enter. And we have efflux pumps. So getting into beta-lactamases is just very overwhelming, and you can really nerd out and learn a lot about the different types of beta-lactamases. And I put this up here just to give you kind of an idea of the overwhelming amount of the different kinds and different families of beta-lactamases. And so we have beta-lactamases that are as simple as just cleaving plain penicillin. And then we now have the super scary ESBLs, we have AMP-C beta-lactamases, we have KPC carbophenamases, and NDM carbophenamases. So, you know, when we're talking about resistance to different beta-lactams, just know that there's a wide variety of different types of beta-lactamases out there. And so really what we're going to do in the coming slides is talk about how the future of different penicillin products and cephalosporin products address all of these resistance issues and address the need for expanding to cover more organisms. As we go through the penicillins, this is sort of a broad overview of kind of how the development within the penicillin class occurred. And so if we have penicillins on the left, obviously one of the huge things that's lacking is gram-negative coverage, right? And then also another huge thing that started to lack very soon after penicillin came out on the market was coverage for Staph aureus. So if we follow the curve that goes up to the right, after the penicillins were developed, the next drug class within the penicillins was aminopenicillins, and they really addressed gram-negative coverage. They also expanded to anaerobes, and unfortunately with the aminopenicillins we started to see resistance in beta-lactamases that start to cleave those drugs, and then we need even further classes like the extended spectrum penicillins, and then we need beta-lactamase inhibitors to tack onto those drugs to protect them even more. On the bottom curve, we're going to address Staph aureus, and so another area is the anti-staph penicillins. We're actually going to do the bottom curve first. So the bottom curve with the anti-staph penicillins, we've got several drugs in this class. Here at this hospital, we use nafcillin as our IV product. However, oxacillin is available in some hospitals in the U.S. as their preferred IV anti-staph penicillin. The oral options in this class are oxacillin and dicloxacillin. Last time I checked, cloxacillin was not available in the U.S. The spectrum for these drugs is really, really narrow. So it's almost as narrow as plain penicillin itself, where these drugs really just cover staph and strep. They're kind of your MSSA workhorse. And if you had an infection with MSSA and then also maybe with strep, you could kind of pick up the strep with these drugs as well. But they're really, really just important for MSSA. And so thinking about the types of infections where you might be just dealing with staph and strep, it's going to be a lot of skin soft tissue infections. Or if you have a more severe infection with MSSA, such as endocarditis or potentially meningitis, these are acceptable options. Now we're going to take that curve, and I'm just going to go back 2 slides. Now we're going to take the curve up toward the aminopenicillins. And so again, what we really gain here is gram-negative coverage that penicillin really didn't have in the first place, and expanded anaerobic coverage. The 2 agents in this class are ampicillin and amoxicillin. Ampicillin is available IV and PO, and amoxicillin is available PO. And some important things about those 2 drugs. The ampicillin IV product has quite a bit of sodium, so make sure you're taking that into account in your sodium-restricted patients. And amoxicillin PO was developed to be more stable against gastric acid. These agents did carry with them the ability to cover staph, but unfortunately the same penicillinase that renders penicillin inactive against staph kind of renders these inactive against staph. So I haven't listed staph coverage up here. What we're going to find, though, is when you put a beta-lactamase inhibitor with these agents, you get staph coverage back. And we'll review that again when we get to beta-lactamase inhibitors. This is an acronym that I'm going to be using as we kind of approach Zosyn and talk about these more resistant gram-negative bugs. And this is the SPACE acronym. It's an acronym to try to memorize some important gram-negative rods that you see clinically where you need to know ampicillin is not appropriate. Cefazolin is not appropriate. You're going to need a beta-lactamase inhibitor. You're going to need a later generation cephalosporin because these organisms most likely or almost always produce resistance mechanisms where you need a more powerful beta-lactam. So the SPACE stands for S for Serratia, which you can kind of also call KES. And so that's Serratia, Klebsiella, Enterobacter. The P stands for either Proteus vulgaris or Pseudomonas. And really that depends on whether or not we're trying to limit this acronym to the Enterobacteriaceae family or not. Pseudomonas is technically not a part of the Enterobacteriaceae family. I guess, now while we're at it, you can throw Proteus mirabilis into the P's too, because it has been known to produce ESBLs as well. Achromobacter and Acinetobacter are the A's, Citrobacter and Enterobacter. And so I wanted to just kind of talk about, with the aminopenicillins, which were ampicillin and amoxicillin, you're really going to be, in today's world of resistance, you're really going to be able to use them kind of over on this category on the bottom left of your screen, where the space bugs, those gram-negative rods that have resistance, they just kind of cleave right through ampicillin and amoxicillin. And so, plain ampicillin and plain amoxicillin are going to be appropriate for a very low resistance gram-negative rod. And sometimes you really don't know, let's say your preliminary report is Klebsiella or Proteus. Sometimes you really don't know in a preliminary report when you're waiting on susceptibilities if you're able to use ampicillin or amoxicillin. So you kind of have to start with Zosyn or Unison or something else. But if your gram-negative rod is susceptible to ampicillin or amoxicillin, you can certainly de-escalate. Okay, getting into the antimicrobial spectrum, again, of the aminopenicillins. So we have gram-negative coverage for kind of low resistance Enterobacteriaceae. There's also coverage for H-flu, and I would say in today's world that's the non-beta-lactamase producing H-flu. And for some of our food-derived organisms like Listeria, for which the aminopenicillins are a drug of choice. Some for Salmonella and Shigella, although I do believe we have resistance mechanisms for those today too. It did, as we started with penicillin and kind of went up to the aminopenicillins, the aminopenicillins did carry with them coverage for strep and coverage for Enterococcus. And so you've probably been taught that your drug of choice for Enterococcus is an aminopenicillin. And that's true. However, the aminopenicillins aren't stable at room temperature for a long time. And so sometimes when we're looking for a prolonged duration, for example, maybe an enterococcal endocarditis, where we know that we're going to need a treat for 6 to 8 weeks, we might be looking for another beta-lactam, such as penicillin, where we can administer it as a continuous infusion. Does have a little bit better anaerobic coverage compared to plain penicillin. And so I think, when we're looking at this drug class and kind of where they fit into therapy, you've definitely got gram-negative coverage, which is going to hit, your GI tract, urinary tract infections. With the coverage against H-flu, that's going to pick up some respiratory infections. And so the aminopenicillins certainly do have a broader spectrum and a longer list of different types of infections for which you can use them. So, oh no, our sad story continues. So poor aminopenicillins, right? They're just kind of not stable enough against all of those different beta-lactamases that we have today. And so we can't just stop with the development of ampicillin and amoxicillin. Now we've got to develop even more potent penicillins. So this is my silly cartoon of, hey, I want to stick this in your genome so that we need more potent antibiotics. So what are those extended spectrum penicillins? Well, we've got the carboxypenicillins and the uredopenicillins, and those are the extended spectrum penicillins, with the most famous agents being ticarcillin and piperacillin. And I'm really not going to talk about these agents alone because they're rarely ever used alone in the U.S. as monotherapy. We almost always see ticarcillin combined with clavulanic acid, and piperacillin almost always combined with tazobactam. However, these drugs are available as single agents in the U.S. They were specifically developed because the aminopenicillins never had coverage for Pseudomonas. And we needed a class within the penicillins that had activity against Pseudomonas. So really, even with Zosyn, when you have that combination with tazobactam and the beta-lactamase inhibitor, really the primary activity for Zosyn against Pseudomonas is in the piperacillin itself. So these drugs are very, very good against Pseudomonas, and typically piperacillin is more potent than ticarcillin against Pseudomonas, and that's one of the reasons of why it's kind of taken over as our anti-pseudomonal workhorse instead of timentin. They do have a little bit less gram-positive activity compared to the previous, call them generations of penicillins, although they're still effective. If you had a mixed infection with strep and MSSA and let's not talk about MSSA yet because we don't have beta-lactamase inhibitors, but if you had a mixed infection with strep, you certainly could use these drugs. And they have excellent anaerobic activity. And I think in the interest of time, that'll be it for that. The next slide reviews the beta-lactamase inhibitors. And so we've got clavulanic acid, sulbactam, and tazobactam. None of these are available as single agents in the U.S. And if you take a look at the structure on the right of clavulanic acid, you'll see that beta-lactam ring. And how these agents work is they bind via suicide inhibition, a covalent bond, to the penicillin binding protein, and they stay with the penicillin binding protein for the life of it. So they're very good in their protection against beta-lactamases. However, we do have beta-lactamases that now can render these beta-lactamase inhibitors inactive. A good example would be an ESBL. So an ESBL is a type of beta-lactamase that renders any of our combination products with beta-lactams inactive. These agents have very little intrinsic antimicrobial activity. However, sulbactam does have some activity to Acinetobacter. And sometimes they do change your side effect profile. So clavulanic acid does have quite a bit of GI side effects. And so when you're looking for a type of respiratory infection, particularly in pediatrics, where high-dose amoxicillin is required, make sure that you're not just doubling up your augmentin to get more amoxicillin, because the clavulanic acid itself can have some pretty bad GI side effects. All right, so now the exciting part. We'll use these agents in combination. So we have 4 combination agents in the U.S., 1 PO and 3 IV. So we have amoxicillin clavulanic acid or augmentin, ampicillin sulbactam or unicin, ticarcillin clavulanic acid or timentin, and piperacillin tazobactam or zosyn. Really what the beta-lactamase inhibitor does when it's in combination with its primary penicillin is it protects the primary penicillin from any beta-lactamase production that might have rendered it inactive. Okay? So, when we're looking at some of our resistance problems, for example, the story of Staph aureus, and how Staph aureus produces a penicillinase that eats straight through penicillin, and it eats through the aminopenicillins, and it eats through the extended spectrum penicillins. The coverage from Staph aureus was there in the first place. It just wasn't stable, against the penicillinase. These beta-lactamase inhibitors will restore that activity, because these beta-lactamase inhibitors will be effective against that penicillinase. And so therefore all of these agents will now have activity again against MSSA or Staph aureus. The problem is you can't apply that analogy to every single organism, because sometimes the resistance mechanism isn't due to a beta-lactamase. So on the next slide, I have a couple examples of when our beta-lactamase inhibitors work and when they don't. So we do have in the very first bullet protection against beta-lactamases, and so we regain coverage for MSSA. You can regain coverage for H. flu and Moraxella catarrhalis, and you can often regain coverage for a lot of those gram-negative rod space bugs, although not all the time, because sometimes our beta-lactamases are now carbapenemases and they kind of eat through everything. Looking at the second bullet, here are some examples of organisms where the resistance problem is not via beta-lactamase production. So therefore, by adding the beta-lactamase inhibitor onto the penicillin, you don't get any additional activity. So with strep pneumo, with enterococcus, and with MRSA, those all have resistance problems either through changes in their penicillin binding proteins or changes with efflux pumps that render those organisms it's not relevant for a beta-lactamase inhibitor, if that makes sense. And then I didn't want to just put these kind of on single slides alone. So just to kind of finish up with our combination products, with Zosyn, looking at all the different things that it covers through gram-negatives and MSSA, Pseudomonas, H. flu, anaerobes, obviously Zosyn is going to have a wide variety of clinical uses, and primarily as a nosocomial agent. We really didn't talk about timentin much, but I did want to add in there as a reminder that sometimes we need to pull timentin off the shelf instead of using Zosyn, particularly for an organism called Stenotrophomonas maltophilia. And I think that's all I really wanted to add on that. Let's talk about another case. So this is a 42-year-old man, which I was trying to get this picture of Nicolas Cage. You know the one where he gets arrested when he's 40 years old, because I Googled 40-year-old man, and there it was. For whatever reason, I couldn't get it off Google Images, so we'll be stuck with this guy on the right. But anyway, we have a 42-year-old man who's admitted for CAP, has a past medical history of hypertension, currently stable on chlorthalidone. Is it stable? I should look at the blood pressure. Yeah, it's not bad. And he's a 25-pack-year smoker. On the inpatient side, because he's admitted for CAP, he's currently on ceftriaxone and azithromycin for CAP. Microbiology, at least on day 2, you call down to the lab, and they say that the blood cultures are positive, 2 out of 2, for gram-positive cocci in pairs and chains. And so that gram stain really gives us a clue that it's probably a strep and not a staph. And ceftriaxone was continued, but azithromycin was stopped. On day 3, the blood culture results, as strep pneumo, and it's susceptible to penicillin. On that particular day, your patient's doing a lot better. He's eating and drinking well, and we've listed the vitals here for you. He's afebrile, and really he's doing well. So you're thinking about discharging the patient. Which of the following is the most appropriate management? Discharge on oral Levaquin to complete 7 days of therapy. Discharge on oral amoxicillin to complete 14 days of therapy. Discharge on oral amoxicillin to complete 7 days of therapy. And switch to oral amoxicillin and discharge tomorrow as stable. The answer here is C. And please don't be scared about the next slide. I know my pharmacy students dread these when they have to learn them. So you don't have to know everything in here, but I did want to point out across the penicillins drug class, there's some important pharmacokinetic elements to these drugs that enable us to choose one drug over the other, right? So just going back to the previous slide really quick. Let's say that B was discharge on oral ampicillin and C was discharge on oral amoxicillin. Well, one important aspect of these drugs is the bioavailability. So oral penicillin V, remember V for vegetable, so the V is the oral product for penicillin. Very poor oral bioavailability. Even ampicillin has very poor oral bioavailability. And so the appropriate answer in that case was C, to discharge on PO amoxicillin, which has much better oral bioavailability than plain penicillin or ampicillin, to complete a total of 7 days. Other things that I wanted to point out here, most of the penicillins are excreted renally. They're mostly not absorbed. They mostly have very wide distribution except for into the CSF. And then the one kind of like which of these kids is doing their own thing within these different classes of penicillins is the anti-staph penicillins. So as pharmacists, we all learn about this drug interaction through the cytochrome P450 system and how it's really eliminated mostly in the bile instead of through the urine, and so we don't need to do a renal adjustment. Any questions on the pharmacokinetic slide before we go forward? I just wanted to kind of point out some highlights. Okay, good. Also looking at adverse reactions across all those different penicillin classes, you're really looking at rash being common, allergic reactions are common, diarrhea is really amplified within the aminopenicillins. Almost all of them, except for the extended spectrum penicillins, tend to cause some elevated liver transaminases, especially at high doses and with long durations of therapy. Plain penicillin and the anti-staph penicillins can cause interstitial nephritis. Let's see, I've got the anti-staph penicillins as vesicants, although plain penicillin IV can also be one, and all beta-lactams can lower the seizure threshold. Really not a lot of food and drug interactions within this class. The oral absorption can be decreased when given with food, and we can have some interaction with birth control, warfarin, and probenecid is kind of your classic drug interaction that we often use advantageously, although I've never seen probenecid used. Probenecid competes for the renal tubular secretion site of plain penicillin in particular, and therefore increases the half-life of plain penicillin. I always hate talking about penicillin allergy because I feel like the data is not great. With a true penicillin allergy, it would be really nice if in whatever study you're reading, everyone had a penicillin skin test, right? Well, that's not always the case. Often it's reported. And so I just wanted to, let's see, I've got plain penicillin. 10% of patients report a history, although I feel like I see it more common than that. Less than 20% of those that actually report a history actually do have a history. And often the IgE-mediated reaction that's sometimes reported in, as a child I had a rash, or as a child I had hives. Often that IgE-mediated reaction wanes into adulthood. The reported cross-reactivity for the penicillins to other beta-lactam classes is listed here, with the first and second generations, or with the first generation cephalosporins having 5 to 10% cross-reactivity, and the second and third generation cephalosporins having less. Carbapenems 1 to 5%, and monobactams. And this really is not what I see necessarily clinically. And so I wanted to let you know that there is some new data. Instead of talking about cross-reactivity with maybe penicillins and all of the first generation cephalosporins or all of the third generation cephalosporins, what they're really looking at is more cross-reactivity of that R group on the beta-lactam molecule. And so looking at maybe some sulfa moieties or nitrogen moieties or benzene rings or different moieties coming off of the beta-lactam ring that really trigger that allergic response instead of an entire class as a whole. While we're on, I'll give you my soapbox a little bit about antibiotics and allergy. There are numerous articles, well-written articles, documenting patients' failure in treatment for various types of infections when those patients received antibiotics that were second and third line and not their drug of class. So I think it's really important, especially when you guys are collecting allergies, to try to get as specific information as possible about that reported allergy and really try to find out, is it something we can challenge or not. We have a patient today that reported a rash with penicillin and it happened in childhood, and so we're really talking about using amoxicillin in that patient. We'll often use a first-generation cephalosporin in a patient with a penicillin allergy. And I think it is important that patients get that drug of choice at all times when possible. We're getting really close to the end, so where is Dr. Maida? Did he? Okay. I certainly don't want to cut off the time for our next speaker. Is the next speaker here? Okay. Hi, how are you? Are you on a tight schedule?
What does that mean?
Well, so I have probably about 10 minutes or so on cephalosporins, which I could do on another day, or we could just do it now. I certainly don't want to...
Up to these guys. You want to finish your cephalosporin?
Sure.
That's fine.
Why not?
You sure? Okay. The cephalosporins go by much quicker than the penicillins. So with the cephalosporins, we do have several different drugs in the class, and really these drugs kind of came on the market in the 1960s. Instead of going through like all the different cephalosporin classes laboriously, I thought maybe a more helpful way of approaching this kind of like largely monstrous group of antibiotics was to kind of group them together and maybe just talk about trends with the generations. So as a general rule, we have 5 generations of cephalosporins today, and they have no activity against Enterococcus, Listeria, and the atypicals. Typically, when you're progressing from the first generation to the later generations of cephalosporins, you start with really kind of strong gram-positive activity, and then as you progress through the generations, you gain gram-negative activity. One exception would be the 4th generation, which is cefepime, and it kind of has it's kind of the best of both worlds. You know, it has really good gram-positive activity and it has really good gram-negative activity. And specifically, I mean for its coverage against the space bugs and Pseudomonas on the gram-negative side, and coverage for strep pneumo and MSSA on the gram-positive side. Here's just another kind of, if you're a visual learner and this helps, looking at gram-positive, because remember, gram-positive organisms stain purple on gram stains, so that's why I picked the purple color. I always teach my students purple peptidoglycan, because peptidoglycan is the outer layer on a gram-positive. These agents start with some really robust, kind of high gram-positive activity, and then it sort of drops, and then in the 3rd generation, we pick that activity back up when we gain strep pneumo coverage. And then on the gram-negative side, starting with the 1st generation, they're just not that potent against a lot of gram-negatives, and as we progress through those different generations, you're picking up more and more gram-negatives as you go through the generations. I really did not want you to have to memorize these, so I put them in a table. And for those of you that arrived late, there are a couple copies of this presentation in the front if you'd like to take one with you. So at least within the first, second, and third generation cephalosporins, we have a wide variety of IV and PO agents. And then the fourth and fifth generation are really just IV with cefepime and ceftaroline. Another kind of broad picture slide here, because I wanted to get into specifically some gram-negatives and sort of when they pick up in the generations. Starting all the way over on the left with the first generation, we have activity against MSSA and strep pyogenes, our famous group A strep. And the gram-negative organisms that are typically covered by this drug class are Proteus, E. coli, and Klebsiella. As you progress to the right, the MSSA coverage stays, the strep pyogenes coverage stays, and at the bottom we start to pick up a few new gram-negatives. So we get those respiratory pathogens, Haemophilus and Moraxella. Going into the third generation, you see strep pneumo popping up in the third generation. And then also, if you go down to the very bottom of the slide, we see some important gram-negatives also popping up. So we have coverage against some of those space bugs, particularly ceftazidime, which covers Pseudomonas. And if we go all the way to the right, then you've got the fourth and fifth generation also covering a lot of those agents and getting even more broad spectrum. I think one really important teaching point here is that the fifth generation is not building upon the fourth generation. So the fourth generation, which is cefepime, I kind of talked about it's sort of the best of both worlds on the gram-positive and gram-negative side, where it has coverage against Pseudomonas and the space bugs, and it also has coverage against MSSA and strep pneumo, and it's great. The fifth generation drug, which is ceftaroline, is not building upon that. So I'd like for you to think of the coverage of ceftaroline as ceftriaxone with MRSA coverage, or cefotaxime with MRSA coverage. So really it's got, good coverage for gram-negative rods except for Pseudomonas, and it has MRSA coverage. We currently do not have any antibiotic on the market to date that covers both MRSA and Pseudomonas. Okay, and then just kind of briefly talking about different uses for these drugs. So in the first generation, if our coverage is primarily staph and strep, and a few of those gram-negatives, we're going to see use for SSTIs and UTI. Perhaps also for group A pharyngitis and also for surgical prophylaxis. Getting closer to the third generation, that's where you'll see some use for respiratory infections, intra-abdominal infections pick up. And then, have one slide on third generations next, which we'll talk about that. And then as you get all the way over, we're going to have a lot more nosocomial coverage with cefepime. Some important teaching points about some of the third generation cephalosporins, particularly ceftriaxone and cefotaxime. They really have kind of an identical spectrum, but they're used very differently in different patient populations. So ceftriaxone is kind of we use it a lot in adults, even in children actually. It's dosed once daily, and that's because of its high protein binding. So where almost every other drug we've talked about today has a very short half-life and is dosed multiple times a day, this is one really advantageous pharmacokinetic manipulation of that drug. With its high protein binding, it can be once a day, and in severe infections, it's twice a day. Ceftriaxone is not for use in neonates, and so you'll probably never see it in the NICU. It can cause kernicterus through that high protein binding, and so typically cefotaxime is used instead in the NICU. Both penetrate the CNS relatively well, although if you look in your Sanford guide, you're going to be confused, because the Sanford guide says that your penetration is really only 8 to 15% in the CNS. But it's enough drug so that you get your concentrations above the MIC for an adequate amount of time. And they do have more penetration compared to other drugs in this class. You do need to use high doses, particularly for treatment of strep pneumo. And we did talk about making sure you review your antibiogram. And before you use a penicillin, in particular for strep pneumo, remember you need to tell the lab what kind of infection you're treating. Both of these are drugs of choice for CAP as well as treatment of gonorrheal infections. I thought you might be interested in some of the new cephalosporins that are coming out on the market. We do have ceftobiprole, which my student, Trammy, who's sitting in the front, is going to review in her journal club tomorrow. So one really interesting thing about this antibiotic, it will be the very first antibiotic among any drug classes of antibiotics to cover both Pseudomonas and MRSA. It also has coverage against Enterococcus faecalis and strep pneumo. Probably the next drug, ceftolozane tazobactam, is the next drug that you might possibly see coming out on the market. It is up for review in December 2014, and I didn't find a brand name, although, Lynn, do you know what it's? Okay. So for right now, just know ceftolozane tazobactam, currently under the development of Cubis Pharmaceuticals, which also does daptomycin. It will be stable against ESBLs, and it will have activity against Pseudomonas. Another drug, which is ceftazidime avibactam, is kind of shortly coming after that for review in early 2015, currently being called Cas-Avi, and it's this unique combination of ceftazidime with a new, hard to remember this, it's a non-beta-lactam beta-lactamase inhibitor, right? So remember for clavulanic acid, sulbactam, and tazobactam, those all looked like beta-lactams, right? And had suicide inhibition through the covalent bonding with the PDPs. It's a beta-lactamase inhibitor with a completely different molecular structure and different mechanism of action. This is going to be interesting because it's stable against ESBLs, KPCs, and some of our other beta-lactamases, and I won't get into those dorky names like OXA and yeah, I just won't get into it. The last one is ceftaroline avibactam, may be coming out sometime in 2015, we're not sure. And so with that ceftaroline being part of the structure, it'll have activity against MRSA, but then also against potentially ESBLs, KPCs, and some other beta-lactamases. I think right now that drug might be on hold as the company is really pursuing the drug ahead of it, the ceftazidime avibactam. They're pursuing that one more aggressively. With the cephalosporins, again, kind of a scary table here, but I wanted to point out a couple things. With the first and second generation, we have great bioavailability, right? So if your patient's on cefazolin and you need to switch to Keflex, you've got a great oral bioavailable option there to switch to. Unfortunately, though, as you get to the third generation cephalosporins, the bioavailability really drops. And so if you have a patient on ceftriaxone, for example, and it's kind of a more complex infection and you're looking for an oral agent, I don't know that I would really recommend switching to a third generation cephalosporin, just because that bioavailability isn't as great. The distribution is relatively the same as penicillins. Your distribution into the CNS really picks up in the third and generation cephalosporin. These are all not metabolized and pretty much all renal in their elimination. Looking at adverse reactions, there's really not a whole lot different than plain penicillins. And we've got maybe an increased risk for C. diff with the third and fourth generation cephalosporins. And this biliary sludge that we kind of talk about on rounds sometimes and I've really never seen with ceftriaxone. Just as a reminder that all beta-lactams can lower the seizure threshold, even the cephalosporins. They can cause hematologic issues and interstitial nephritis. I know that, and this has been published, so I can definitely say it. You know, I know in some of our experience with high-dose cephalosporins, either ceftriaxone or ceftaroline, we do actually see in this hematologic category some neutropenia that occurs from that high-dose beta-lactam. So that's something that us as the clinical pharmacists are following in your patients to make sure they're not having toxicities. The last bullet is really not as much clinically relevant because we don't use these cephalosporins anymore, but just in case it's something that pops up on your boards, there are 4 cephalosporins, cefotetan, cefmandel, cefparazone, and cefmedazole that have some unique characteristics. One is vitamin K antagonism, and so that can increase your bleeding risk. And another is a disulfiram reaction, which we typically just think of with metronidazole, but that can happen with these drugs. Not a lot of food and drug interactions that you really need to know about, and that's